Hello, everyone, and thank you for joining us for the second event in our three-part series, Nurturing the Three Sisters, Community, Culture, Connection, and Urban Indian HIV Care. The long-standing Indigenous practice of companion planting the three sister crops of corn, beans, and squash allows them to all grow strong together. So too does Urban Indian HIV Care thrive with culturally grounded practices that foster connections between us all. Today, we continue the series with a discussion on serving gender and sexual minorities in HIV care titled Growing Strong Together, creating 2SLGBTQIA+ inclusive healthcare service. Next slide, please. My name is Margot Bailowitz, and I am a Public Health Associate with the Technical Assistance and Research Center, also known as TARC, at NCUIH. Joining me from the NCUIH team are Kayla Emmerich, Public Health Associate, and Rachel Dio, Communications Associate. We are honored to have you all here today. We kindly ask that you place your name, organization, tribal affiliation, and title into the chat box. In addition, we welcome any feedback you would like to provide about your webinar experience in our survey, which is posted in the chat box. Next slide, please. I would like to bring to your attention a brief disclaimer that this event is made possible by the Minority HIV/AIDS Fund through the Indian Health Service. Next slide, please. As shown on the agenda, we will begin with the session overview and some housekeeping, followed by an introduction to our wonderful presenters and the presentation. We will end the session with a Q&A and adjourn promptly at 3 p.m. Eastern Time. Next slide, please. For those of you that are unfamiliar with NCUIH, here's a little background. The National Council of Urban Indian Health, also known as NCUIH, is the national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives, or AIANs, living in urban areas. NCUIH is the only national representative of the 41 Title V Urban Indian organizations, or UIOs, under the Indian Health Service in the Indian Healthcare Improvement Act, or IHCIA. NCUIH strives to improve the health of over 70% of the AIAN population that lives in urban areas, supported by quality, accessible healthcare centers. Next slide, please. As we dive into our session, here are just a few things to keep in mind. The session is being recorded. All mics have been muted unless otherwise directed. Questions can be typed into the chat box. Q&A will follow at the end of the session. And please note the QR code that's at the bottom of the slide. You can scan this with your phone to access our feedback survey. Next slide, please. To ask a question, first select chat at the bottom of your Zoom screen, then type your question or comment into the chat box that will appear on the right of your screen. Next slide, please. I will now introduce our presenters for today's session. Cornelia Connie Jessen, MA, has worked in the Alaska tribal health system to address health disparities among Alaska Native and American Indian people for the past 15 years. Ms. Jessen has been involved in several community-based participatory research and programmatic projects, ranging from sexual and reproductive health, adolescent health, HIV stigma and discrimination, to harm reduction, substance misuse, and intergenerational trauma. Her research focuses on understanding the intersections between culture and health, the role of resilience and protective factors, and translating cultural knowledge and practice into interventions that promote health and wellness. She also oversees cross-cultural research education and training efforts to decolonize health research and promote culturally responsive and respectful research. Hannah Warren, she, her, hers, is the HIV STD Prevention Program Manager with the Alaska Native Tribal Health Consortium. She is an enrolled member of the Chivak-Kitsunamute tribe located in Chivak, Alaska. Hannah graduated from the University of Alaska Anchorage with her Bachelor's of Science in Health Sciences with minors in Alaska Native Studies and Psychology. Hannah additionally holds a Master's of Public Health in Public Health Practice, focusing her studies on healthy relationships and sexual health and wellness education among the circumpolar North. In addition to having a passion for harm reduction and sexual health and wellness education, Hannah is an advocate for incorporating cultural competency and trauma-informed care into services for Alaskans. Next slide, please. Before we begin our presentation, we're going to pop up our first knowledge check. Please select your answers for the following questions in the pop-up box. Rachel, if we could please get up the knowledge check, and we'll give everybody about 30 seconds to answer the question. And we have about 10 seconds left to get the final answers in. All right, and Rachel, if you want to flash up the results, please. All right, perfect. Well, thank you all so much for your wonderful answers. We'll now turn the floor over to Connie Jessen. Let us give a warm welcome by placing a heart emoji in the chat box or using a heart reaction. And Connie, the floor is yours. Next slide, please.
Hello, everybody. I just want to say thank you to the entire NCUIH team for the invitation and for facilitating today's presentations by Hannah and myself. And we are just going to talk to you today about growing strong together, creating two-spirit LGBTQIA plus inclusive healthcare services. Next slide. What we also would like to do is we are coming to you from Anchorage, Alaska, which is the home of the Dena'ina people. And we just want to recognize that we reside on their traditional lands, and we acknowledge the Creator and all Indigenous people of Alaska. Thank you for your past and present stewardship of the waters, plants, animals, and spiritual practices of this place. And we'd also like to recognize the traditional lands on which those of you who are participating are residing today. For our learning objectives, we'd like to talk about experiences and work that we have done and convey that to you so that you'd be able to identify challenges faced by Alaska Native people who identify as two-spirit LGBTQIA+, being able to differentiate between affirming sexual health history practices and stigmatizing language, and apply inclusive language and improved structures at your clinic or place of work. For my part, I'm just going to share with you findings from a community health survey that we conducted a few years ago, which was with Alaska Native people who identified as two-spirit LGBTQIA+. And the project was also funded by the Minority AIDS Initiative through the Indian Health Service. So we want to give thanks for that funding that provided the opportunity for us to engage in this work. For us, so I know that Margot read my bio, but for many years I was involved in HIV/STD prevention work at the Alaska Native Tribal Health Consortium before Hannah took over and is moving forward with a lot of our efforts. And so we, at the time, back in about 2017, we initiated this project as part of our iknowmine.org two-spirit LGBTQIA+ HIV/STD outreach and prevention efforts. Excuse me. And when we started out, we realized that there really was a lack of Alaska Native specific health data and information. So we set out to create a community health profile that would help us better understand what Alaska Native two-spirit LGBTQI+ people and the community identified as needs. I'm going to just go really quickly over the study design and what we did, because I don't want to take up too much of your time because Hannah has a lot to say as well. But we started out with an advisory committee to inform the study. In example, the survey instrument that we utilized and adapted and created, the outreach that we did, the data presentations that we're doing today. The survey itself that we conducted was a cross-sectional self-administered online survey. So we had lots of questions around demographics, sexual orientation, gender identity, sexual mental health, substance use, cultural connectedness, healthcare experiences, as well as experiences of discrimination and violence. We did utilize scales and questions that came from a variety of national and local survey instruments, and we adapted them to our needs. We started out with SurveyMonkey as our data collection platform, but I will tell you a little bit about that experience, and then later moved to a RedCap platform, which is it's a free platform for data collection that ANTHC has a license for, and that other institutions use as well. The criteria for participating in the survey was self-identification as Alaska Native or American Indian, 16 years and older, Alaska resident, and then also self-identified as Two-Spirit LGBTQIA+. Next slide. So in terms of recruitment, we did this as a convenience sample. We distributed traditional flyers at fairs and events throughout the state. We disseminated the information through advisory committee and the community networks of people on the advisory committee and our own networks. We started out using social media, which included targeted Facebook and Instagram ads. And at that time, we were using SurveyMonkey, and this is where we experienced a huge flood of responses that we realized were primarily spam. So that was the incentive for us to stop the survey, and then go back to the drawing board and find a more secure platform and a different way to do it, because we realized that we couldn't use a lot of the data. And the other added part of that was that we offered a $25 electronic Amazon gift cards and t-shirts from iknowmine.org, which kind of added to people wanting to do the survey that didn't necessarily meet the eligibility criteria. So that is one of the big lessons that we learned through this project. Next slide. So in terms of the data collection, then what happened is we started in June 27 and went through September 2017 on SurveyMonkey. And that's when we realized that through all the social media outreach and the incentives, we had about over 1,000 responses. And when we started looking at the responses, we looked at IP addresses, and lots of them were not Alaska-based. They were from all over the world, essentially. We identified a lot of random click-throughs, essentially meaning that people really just quickly moved through about 5 to 10 minutes for a survey. They should have taken at least 35 to 40 minutes. And so we halted the survey, as I mentioned, and moved over to the RedCap platform, because that increased our ability to include a lot of different validation strategies that are part of the RedCap platform. So we went back to the drawing board and worked on revising all of our protocols, research protocols, survey protocols, and then launched again in February 2018 and ran the survey through June 2019. When we did all of the data cleaning, we ended up with a final sample size of 195 surveys from SurveyMonkey and 69 surveys from RedCap. And so we combined those surveys and began our data analysis. Next slide. So the final analytic sample was 264 survey responses. There was some variable transformation that was happening on the back end for data analysis. We created different dichotomized variables. We created a sexual risk variable, and then we conducted descriptive statistical analysis, basically frequencies and so forth, and then it did a test of independence to see if there's any results that are really statistically significant. Next slide. So in terms of demographics, we had targeted 16 and older, so our sample size consisted about 34% 16 to 25-year-olds, 53% 26 to 40-year-olds, and 12% 41 and older. It was about split half and half between rural and urban participants. Self-identified 97% as Alaska Native. And in terms of income, we had 63% who reported at or below $39,999 and 37% above. In terms of the main findings that we identified through our analysis, in terms of, next slide. mental health, we found that, if you go next slide, please, we found that about 68% reported restless sleep in the last week. And so these were all reported symptoms of depression and suicidality. 65% reported feeling depressed in the last week. 94% had thought about suicide in their lifetime, and 45% had attempted suicide in their lifetime. But on the other side, people also reported experience happiness and hopefulness about their future. Both of them 93% and 92%. The other area that was really showing a lot of findings was violence and discrimination. And for that, next slide, we were looking at reported experience of violence and discrimination based on sexual orientation and gender identity. So 71% of all respondents reported being sexually assaulted in their lifetime because they were Two-Spirit LGBTQIA+. 58% reported having been harassed by others in the community because of their sexual orientation. 64% of transgender, gender nonconforming respondents reported physically, sexually, verbally, or emotionally being assaulted by a partner because of their gender identity. Next slide. Of course, we were asking lots of questions around sexual health because that was one of our main focus areas. Next slide. In that category, we found that respondents with more than one sexual partner and engaging in anal or vaginal sex without a condom in the last 6 months were more likely to be 16 to 25 years of age, have an annual income under $39,999, have less fear in disclosing to medical staff, but having tested positive for gonorrhea in their lifetime. Some of this is probably because of the young age. We had a pretty, at the time that we conducted the survey, we had a large proportion in that age category. So that's probably reasons for these findings. Next slide. We also asked about pre-exposure prophylaxis or PrEP. We had questions about, have you heard of PrEP? Has your health provider talked to you about PrEP? Or have you taken PrEP while having anal or vaginal sex in the past 6 months? In terms of the knowledge, the yes is in the blue and the no is in the green, and then the little light blue, not sure. Knowledge was about a little more than half of the respondents said that they had knowledge. A little more than 35% indicated that they had talked to their healthcare provider about PrEP. But if we, when we asked about, have you taken PrEP when you were engaged in high risk, there's only about 15% or so who utilized PrEP. And then no was the largest. And then there's also a chunk of people who weren't sure, which is another reason to believe that maybe they didn't really know about PrEP that much. So there's certainly more to be done in that area. Next slide. In terms of condom use in the last 3 months, about 79% reported condom use during anal sex, about 54% reported condom use during vaginal, and 22% during oral. We also had a component of the survey that asked about healthcare access and barriers. The next slide. So there were reported stigma and other barriers to accessing healthcare services. About 81% reported community fear and dislike as a problem in receiving healthcare services and opportunities. 75% reported not enough psychological support. 72% reported that they or indicated that they did not have enough mental health care professionals to go to when needed, and 71% reported fearing the providers will treat them differently if they disclose their sexual orientation or identity. We also wanted to know, though, how much people were connected to their culture, and we did that by utilizing, next slide, what is called the awareness of connectedness scales. That was developed for Alaska Native people, and we looked at different areas of connectedness. And so this is about how aware people are to cultural connection to self, to their family, community, and nature. And when we looked at that, the first biggest connection was to nature. Respondent reported high levels of awareness to their connectedness with nature. Respondents reported sort of a mid-level awareness of the connection with self to identify as Alaska Native and their culture. The next one, lower one, was connection to family. And then the one that was the lowest was connection to community. Next slide. And so this is what that looks like. Awareness of connectedness scale was a rating from 0, no, to 20, yes. And we looked at medians, and the questions that are related to these different areas are, I treat animals and the land with respect, like they are my family is one example. When my family is happy, I am happy. Another example is for individual connectedness, I like to share without expecting things back. So these are some of the cultural values associated with these cultural aspects of connectedness. And then the one that scored the lowest was my community believes I am important. Next slide. So in terms of what all of this means, or to summarize everything really, next slide, we can really say that our participants reported high levels of stigma, discrimination, and violence experiences. They also had high levels of mental health challenges, especially depression and suicidality, high levels of fear to disclose to providers, high levels of hope and happiness, though, as well, lack of access to mental health services. And when they did have access, they reported lack of psychological support. And then also strong cultural connection to the natural environment, but they're less likely to believe that they are important to their community. And when we think about the implications of those findings to the work that we do in prevention and health services, we can look at that different identities and experiences of participants shape the health and well-being as they identify as Alaska Native and Two-Spirit LGBTQIA+. And we really need to look at improving access to mental health services and psychological support to address mental health challenges. We need to look at increasing provider, Alaska Native, Two-Spirit LGBTQIA+ education and training to address healthcare stigma. We need to provide more community awareness and education to create community connection and also address stigma and discrimination, as well as violence experiences. And when we look at sort of the group of individuals from the survey that it really could benefit from culturally based sexual health promotion and outreach is really the age of 16 to 25 years old, based on our findings. And of course, we did have several limitations. This was just a cross-sectional survey, so it's really hard to make any causal connections and associations. And then we engaged, in convenience sampling. So there is some selection bias so that people who were really wanting to talk about their experiences were the ones who actually completed the survey. And then obviously the results do not fully represent all Alaska Native people who identify as Two-Spirit LGBTQIA+ or other American Indian individuals living outside of Alaska. But we definitely have a lot to be thankful for in this project. And especially we're thankful to the members of our Alaska Native Community Advisory Committee that provided support and guidance throughout the project, and also provides guidance and support as we are writing up our results for our manuscript. So a big thank you to all of them. And thank you so much for all of you for being here today. And I'm going to pass on to Hannah.
Thank you, Connie. All right, let's go ahead and dive on in. Next slide, please. So I really hope to be able to build upon what Connie shared in her slides. So here's an overview of what we'll be discussing today. We're going to be starting off with an overview of what stigma is, and then we're going to be going over what affirming care is and how that relates to inclusive language, where we'll also be going over some of the more common terms and definitions related to the 2SLGBTQIA+ population. We'll also be reviewing how to incorporate inclusivity into your sexual health discussions. And then I will be wrapping up my portion of the presentation with some resources at the end where you can go for more information or access education tools or other programs for your work. And then, of course, there's going to be time for questions at the end. All right, so stigma. Stigma is a lack of respect for a person or a group of people because they have done something or they have traits of which society disapproves of. There are many ways to describe specific types of stigma, but speaking in more of a broad sense, here are the 3 forms of stigma. So there's self-stigma, which is when somebody internalizes negative stereotypes. This is often perpetuated to them by public and institutional stigma. And this is really when they believe the stigmatizing thoughts that are being perpetuated against them. There's also public stigma, which is when someone or a group of people faces discrimination by others. And then institutional stigma, which often involves policies and laws that result in reduced or no access to care for a person or a group of people. And sometimes, but not always, institutional stigma is heavily influenced by public stigma. Next slide, please. And so when it comes to this population, these forms of stigma pop up in everyday life and every time somebody seeks or even considers accessing care. So they might not know if it's safe or if they have to defend their identity or be their own advocate yet again, or even that they don't feel that maybe they're not worth the effort that it will take in order to get the care that they need. And so what Connie highlighted in her portion of the presentation, or at least in part, is that stigma still persists towards this community today in all of its forms. It is still very persistent despite all of the advances that have been made over the past 10 years or so. And so stigma is still a significant barrier for creating what's called safe spaces for the 2SLGBTQIA+ community, even today. Next slide, please. And so safe spaces are essentially exactly what the name implies. It's a place for people to just be themselves, bring their entire authentic true selves without judgment or discrimination. A safe space is there to provide support to people and meets people where they're at. A safe space can look like different things. It can be a place to just talk and listen, a place to find strategies to overcome barriers. Essentially, a safe space is what somebody needs and is ready to tackle in that time. And so in the sense of cultivating a safe space for 2SLGBTQIA+ communities, this can look like providing what's called affirming care. Next slide, please. And so what affirming care is, it is client-centered. Affirming care believes and supports a client by validating their experiences. Providing affirming care also means to recognize that the client faces unique challenges and to be an advocate for their health needs by taking steps to overcome them, regardless of what those might be. Whether that's providing them the health care that they need or even helping them to find a safe place to access that care in order to have their needs met. And so affirming care involves people who are inclusive and knowledgeable about the population that they serve. It actually encompasses a lot of different practices and strategies that exist to support these communities today. For example, you might have heard of gender affirming care, which is care that helps the client by aligning the physical body with the client's gender identity. And that type of care typically takes place in specialty clinics. However, with that being said, I wanted to remind folks that 2SLGBTQIA+ people don't just exist in spaces specific to specialty clinics like these. They have been in shared spaces everywhere since time immemorial. Stigma and discrimination have just made it to, where it's hard or even dangerous to exist as someone who is part of this community. And so to that point, there are ways that we can all practice affirming care in every single one of our spaces, whether that's in specialty clinics or primary care, case management, social work, education, and even more. Next slide, please. And so one of the biggest ways to practice affirming care is to listen to and believe your client if and when they come out to you. You can validate their experiences and show that you support them by asking if they have what's called a chosen name or pronouns, and by using these every single time that you meet with them. You can note this information in their chart or in their case file as a quick reminder to yourself in order to use their chosen names or their pronouns every time that you meet with them. You can also show your support and signal that you're a safe person by posting, say, gender-friendly posters in rooms, or by wearing rainbow swag like a pin or a badge reel. And then also be willing to admit that you don't have all of the answers. But you can, when speaking to your client, to commit to finding them along with them, and you can verbalize that to your client as well. And then also continue learning about the relevant issues, which I think is why we're all here today. Speaking of which, one of the main topics that people go to when they're starting out their education in this field of providing 2SLGBTQIA plus inclusive health is trying to find out what all of the relevant different terms mean, which is actually what we're going to be exploring next. All right, so in this section, we are going to be going over some of the more introductory terms related to identity, orientation, and expression as well. Next slide, please. All right, so what I have popped up on the screen in front of you today is called the Gender Unicorn, and it's provided by the Trans Student Educational Resources at transstudent.org. And it goes over different sections related to identity, expression, sex assigned at birth, physical attraction, and emotional attraction, which is what we're going to be going over now. But before we do, I want to note that identity, orientation, and expression are all fluid. And this means that they can change. There's no black or white identity. And they're actually all on a scale, and you don't have to just choose one. So starting off with gender identity. Gender identity is one's internal sense of their gender. So they could identify as male, female, neither of these, both, or another gender entirely. Everybody has a gender identity. And for transgender people, their sex assigned at birth and their own internal sense of gender identity are typically not the same. So whether someone identifies as female, woman, and girl, or male, man, and boy are also not necessarily linked to each other, or even all encompassing gender identities. For gender expression, a lot of people also refer to this as maybe presentation. And so this is the physical manifestation of one's gender identity through their clothing, hairstyle, or other physical attributes. And so many transgender people seek to make their gender expression match their gender identity. So matching how they look with who they are, rather than their sex assigned at birth. As far as sex assigned at birth, this is the assignment of people as male, female, or intersex. And these are really the main three, with actually female or male being the main two. And this is usually assigned by a doctor to a person when they are born. And so the term itself, it's really important to use sex assigned at birth rather than just sex, just because the vagueness of the term sex has a very strong place in transphobia. And then moving on to physical attraction, a lot of people refer to this as sexual orientation, as opposed to physical attraction. I do want to note that it is important that sexual and romantic attraction are different, and they can be from a variety of factors, including but not limited to gender identity, gender expression, or sex assigned at birth as well. So you can't be physically attracted to someone without being emotionally attracted to them, and vice versa. And emotional attraction is typically referred to as maybe romantic attraction, although that is not an all-encompassing term. There are, different types of attraction like platonic or aesthetical attraction that folks can feel as well that would fit into this category. Next slide, please. So I just wanted to sum up the terms that we just reviewed, listed as how people usually encounter them with maybe a one-sentence summary of what we just went over. The gender identity being one's internal sense of gender. Gender expression, how a person presents themselves to the world. Sex assigned at birth, typically based on outward anatomy, again, assigned by a doctor when a person is born. Sexual orientation, physical attraction, and then romantic orientation being emotional attraction. And so with all of that being said, one of the ways that we can gauge someone's identity is just to ask someone who they are. What is your name? What pronouns do you use? So I do think that I saw in the chat earlier, someone had pointed out to recommending to use just what pronouns do you use rather than what are your preferred pronouns. I think many of us over the last 10 years or so have gotten used to asking, what are your preferred pronouns? But I just wanted to point out that I have heard that too, is just to ask, what are your pronouns? Because there is a sense of, I want to say maybe stigma towards folks when asking that question, which kind of alludes to people choosing what their identity is rather than it being, something that we are born as. I am born as this person. I'm not choosing to be this person. This is who I am. So next slide, please. So asking, who are you? What is your name and what are your pronouns is the preferred way to go. But in asking that question, you may get varied responses. And this is because that there are no male, female, or man, woman pronouns. It is not black and white, and no gender pronoun is a blanket term for somebody else. Using pronouns is one way to show the world and each other what our gender identity is. And so sometimes a person's pronoun can allude to having what's called a chosen name. A chosen name is a name that someone has picked out for themselves that more closely aligns with their gender identity. And this is most often used for trans or non-binary individuals, trans referring to transgender. And a chosen name is not always what's listed on a legal document like a birth certificate or an ID. But pronouns and chosen names affirm gender identities, and they create safe spaces by referring to people in the way that feels the most accurate to them. And of course, there can be many different types of pronouns, not just she, her, he, him, they, them, ze, zer, ze, her. There can also be she, they, he, they. It's all up to the person how they would like to be perceived. Next slide, please. So to put pronouns into practice, ask every client what pronouns that they would like to use. If you're not sure, it will be okay to use gender neutral terms like they, them. You can practice using gender neutral terms in the workplace. So working on cases with your coworkers or summarizing notes at the end of the day, practice makes perfect. You can also ask your client if they have a preferred or chosen name, and you can either do this by asking them directly, again, what is your pronoun, or what pronouns do you use, what is your name, or even indirectly, do you have a nickname that you'd like to go by, what would you like me to call you? You can also show that you understand the importance of pronouns as well by, again, wearing supportive ribbons, stickers, or even buttons. A lot of prevention programs in your area might have a cool swag like this or even posters to put up in your spaces. Of course, acknowledging that some places might be more strapped for supplies than others. But, another way that you can put pronouns into practice is by sharing them with your clients and your colleagues, sharing your own pronouns with your clients and your colleagues. Verbalize it even if you're showing it. So even if you're wearing some pronoun pins, you introduce yourself. Hello, my name is Hannah. I use she, her pronouns as an example. This tells your clients that you understand and that you respect the concept of gender identity being different than sex assigned at birth. You will also be showcasing yourself as a safe space, a safe place to everybody that you meet. Next slide, please. And so from there, after you've introduced yourself and gotten to know someone, the time might come to initiate a sexual health discussion, depending on where you work, of course. Next slide, please. So if you're working in healthcare, you're probably familiar with and are already using the CDC's 5 Ps guide to a sexual health discussion. The 5 Ps being partners, practices, protection from STIs, past history of STIs, and then also pregnancy intention. These 5 things being the areas that you should openly discuss with your clients. If you're looking for more information or gathering a sexual health history. And so of course, with everybody that you meet, you are going to want to ask additional questions or adjust your questions that are appropriate to each patient's situation or their circumstances. Next slide, please. And there are a lot of ways to do that, but I just wanted to throw out a few reminders when going through the 5 Ps. You never want to make assumptions about sexual orientation or the gender identity of the client or their partners. You never want to assume that somebody cannot be pregnant or acquire HIV or STIs. And then you also never want to assume the kind of sex that someone has. If they bring up a term or something else that you're not familiar with, you can follow up by acknowledging, that you don't have all the answers. You can ask them, I'm not sure what that is. Can you tell me more? Or what parts of the body do you have sex with? Questions like that. Next slide, please. And so sexual health is necessary for everybody's general health, regardless of their gender identity or sexual orientation. And so reviewing this information with your 2SLGBTQIA+ clients is critical to their health. I think also what Connie highlighted in her slides, it rings true across the nation, I think, is that these folks are among the populations at most risk for sexual assault, violence, HIV, and STI rates as well. So reviewing the 5 Ps with your clients can be life-changing in more ways than one to somebody by getting them the care, the treatment, and the preventative services that they need. Next slide, please. And so with this being said, I just wanted to additionally share some actionable items that we can all do in our spaces to increase access to comprehensive care. 1, address health concerns. So believe your clients, when they voice their health concerns with you. Recommend STI screenings for everybody who is sexually active. I want to throw chlamydia, gonorrhea, of course, but then also especially syphilis. Right now, there has been an increase in syphilis rates that is concerning across the nation. And then also becoming familiar with HIV care. Who are your local HIV care team members? Where are the resources for PrEP and PEP, which are HIV treatment medications? And who would you contact if your client needed them? Also becoming familiar with behavioral health and case management support services as well. You can also ask all people, again, their chosen name and their pronouns, and if you're in a capacity to do so, advocate to make it a policy. This will help decrease assumptions, decrease stigma, and it will normalize these kinds of conversations for everybody across the board. And then also review your internal forms for greater inclusivity. For example, registration forms or entry forms. Is there a place to even write down a chosen name or even pronouns in addition to a legal name? In the demographics or data collection section of the forms, is there a space to enter identities like non-binary or information related to transgender status? Or is there an option to edit sex to sex assigned at birth? Next slide, please. So I'm going to go ahead and review some resources in this section. Next slide, please. So speaking to Alaska folks, if you're on the call today, I want to point you to a program website that I oversee, which is called iknowmine.org. What it is, it's a youth, Alaska Native and American Indian focused youth website where this population can go ahead and access all sorts of information and education about sexual health and wellness, alcohol, tobacco, and other drugs, LGBTQ2S+, and more for free. For the providers on the call based in Alaska, you may find more benefit in our online store. Next slide, please. Where we offer a variety of HIV and STI prevention supplies for tribal organizations, other nonprofits based in Alaska for free. And we do send out certain supplies in bulk to these locations as well for distribution to their communities. And then also individuals in Alaska are able to order these types of supplies as well. So there's condoms that people can order, HIV self-testing kits, STI cards, and other educational materials too. Next slide, please. I want to highlight the Trevor Project, which is just a wonderful resource bank of, a lot of information and education and just a ton of tools available for 2SLGBTQIA+ folks. One of the resources that they have on their website is this guide to being an ally to transgender and non-binary young people, which is posted on their site. Next slide, please. The PAS Remember project at pasremember.org is a website and a resource bank that centers Two-Spirit and the LGBTQIA+ community. There is a free toolkit on their website that you can order or download that offers information on creating Two-Spirit and LGBTQIA+ affirming spaces. Next slide, please. The I Want the Kit program at iwantthekit.org offers a free STI self-testing program where people can have a testing pack for chlamydia, gonorrhea, sometimes trichomonas, delivered to them directly, and then they can then test in a private space of their own choosing. It's a self-swab collection program, which they then have to send back to the Johns Hopkins lab for testing. But the I Want the Kit program will then process completed tests through their lab at the Johns Hopkins University and then notify the client of their results. Alaskan folks can order a test kit for free, costs completely covered by the Alaska Native Tribal Health Consortium. Next slide, please. Native Test is a program that sends out free HIV self-testing kits to people across the nation. They use the OraQuick HIV oral rapid test kits. And to order one is super easy. All you got to do is text Native Test to 55251 or scan the QR code for more information as well. Next slide, please. So Healthy Native Youth has a resource bank of different curricula and programs for sexual health and wellness education available on their website. They have a variety of other programs and curricula on there too for different topics as well. And I did want to highlight their community of practice sessions, which are held about once a month, where people gather to learn from topical experts. So they've done text message campaign workshops, behavioral and emotional health topics, conversations around sexual health and wellness with youth and young adults. So be sure to check it out. Next slide, please. So recently developed and released, this is titled the Indigenous HIV/AIDS Endemic Strategy, weaving together the national HIV, STI, and viral hepatitis plans. And so this was really developed to support the development of comprehensive solutions to end the HIV epidemic in Indian country. So this document contains, emergency practices, existing initiatives, as well as traditional and Indigenous knowledge in order to aid in the development of community-tailored interventions to address these endemics. And so the Indigenous plan was developed by the Northwest Portland Area Indian Health Board alongside IHS in their national HIV program, as well as other partners as well. Next slide, please. And then I also wanted to share that a new SAMHSA report came out with what they're calling a roadmap which is titled Moving Beyond Change Efforts, Evidence and Action to Support and Affirm LGBTQI+ Youth. And so this report provides behavioral health professionals, researchers, policymakers, and other audiences with a comprehensive research overview of their research and information about different practices related to LGBTQI+ identity. Next slide, please. I just wanted to do a shout out. I am very grateful for the funding that is, funding the work that I do through Project Red Talent, the Healthy Native Youth Program. They are supported in part with funds from the Secretary Minority AIDS Initiative Fund, the IHS, HIV, and behavioral health programs. Next slide. Here are some of the links that I used. Next slide, please. Are there any questions?
Great. Well, thank you so much to Connie and Hannah for that amazing and informative presentation. Please place an applause emoji in the chat box. And before we begin our Q&A, we'll just do a quick final knowledge check that will pop up. So please, again, select your answers to the questions in the pop-up box. Rachel, if you want to get that up, please. And we'll do about 30 seconds again to give everyone time to respond. All right, Rachel, and if you want to flash up the results, please feel free. Awesome. Thank you so much, and thank you all for answering. The floor is now open for any questions or comments that you may have about today's presentation. So please feel free to turn on your cameras and come off mute, or place your questions in the chat box. And I just wanted to highlight one comment that I'm seeing in the chat from Jalen. They say Rainbow Youth Project USA is also a great resource for Two-Spirit LGBTQIA+ youth. They offer crisis services, connecting to mental health services and homeless services, and as their URL there. Thank you so much for providing that resource. Kayla, anything that I missed in the chat from earlier?
No, I think you're right on top of it. That's great. Thanks for sharing that one.
Awesome. Well, please feel free to type any questions in the chat or come off mute.
Hello, I have a question for Connie regarding the survey. I actually implemented a survey quite similar to yours in California. And I'm just wondering, we with the results stemming from the survey for the need of mental health services and all these systemic changes that need to happen, do you have any recommendations that can be, done more in the moment regarding outreach materials or kind of what we can do? I'm not a direct service provider, rather an education outreach coordinator. Just kind of stemming from those results you got in the survey, I just wanted to ask, what are some things maybe I can do in this line of work?
I personally feel like from those results, it just seems like providing any mental health services, information, or resources in whatever area you work in or provide services in is important, because it seems like access to specific psychological support, like mental health specialists, especially up here in Alaska, is sometimes challenging. So if primary care providers or providers in different areas of health can provide similar, at least resources, then maybe they can close that gap. I feel like that seems to be, since there's such an access issue. And I'm thinking specifically about our rural communities in Alaska and even in the lower 48, where specialists are sometimes hard to find. It seems like that the more we can push out resources, information in the different clinics to different providers in different fields, the more likely it is that somebody will get the need the help that they need. If that makes sense.
And we do have another question in the chat as well. As Zachary asks, are there any community outreach programs that you're aware of focused on combating stigma against sexual and gender minorities within Native communities?
So the one that comes to mind that's available for lower 48 folks as well would be with the Healthy Native Youth Program. They have this campaign, text message campaign called Talking is Power, where, when folks enroll in it, it could be a parent, it could be a caregiver, educator, they'll receive regular information on how to start and maintain a discussion around sexual health and wellness with Native youth and young adults as well. And, it's tips and tricks, but then there's also words of encouragement, affirmations as well, different videos and examples of how to start those conversations. So I can find a link and maybe put that in the chat if you'd like to take a look at that some more.
Yeah, we're also happy to provide some links and a list of resources, since Hannah, especially at the end of the presentation, shared so many excellent resources there. We can send that out after the presentation as well.
It's not a community outreach program per se, but it's somebody, an entity that has helped us provide training around how to potentially engage in outreach to address some of this. Is Escalate. And I'm happy to share some information with Kyla and Margot about that, but they do a lot of trainings around stigma, and they've also just recently moved to doing that online, so it's accessible to anybody anywhere. And so maybe that's just to help support any grassroots efforts perhaps, or train people on how to go about creating outreach programs.
Great. Well, thank you all for your questions. Thank you so much, Connie and Hannah, for those responses. If anyone has any final questions, please feel free to drop them in the chat. But otherwise, thank you so much for joining us for the second session in our Nurturing the Three Sisters series. We also thank our presenters for the wonderful presentation. Please let's show our appreciation with the celebration reaction or celebration emoji in the chat box. And we appreciate any feedback you would like to provide about your session experience. Please complete our session survey by using your phone to scan the QR code that's on the slide, or by clicking the link that will be placed in the chat box. And those who complete the evaluation will have a chance to receive a mystery NCUIH swag item. So thank you for your responses. And next slide, please. So NCUIH is hosting many upcoming events that we would love for you all to join. Some of these events include on April 26th at 2 p.m. Eastern Time, Standing Together to Address Urban Indian STI Disparities, Strengthening Syphilis Care in Indian Country. And then on June 8th at 2 p.m. Eastern Time is the third session in our Nurturing the Three Sisters series, which is called Branching Out, Wellness Programming for Patient-Centered HIV Care from an Urban Indian Perspective. And lastly, please save the date for NCUIH's annual conference, which will be held this year in Washington, D.C. from May 15th to 18th. And please visit ncuih.org/events for more information and for registration links. Next slide, please. And thank you all again so much for attending, and thank you so much to Connie and Hannah, and have a wonderful rest of your day, everyone.